Okay, good afternoon everyone. I'm Deborah Reeves, the Coordinator of Research Services in the Library. Firstly, on behalf of the Parliament of Victoria and its members, we acknowledge the traditional owners of the land on which we gather today. We pay our respects to them, their culture, their elders past and present, and we also pay our respects to people from First Nations communities who may be joining us. I welcome you to our seminar about curbing antimicrobial resistance, which we're presenting jointly with ATSI, the Australian Academy of Technology and Engineering. Our moderator today is Professor Bronwyn Fox, who is the Chief Scientist of CSIRO and a member of the ATSI Victorian Division Committee. Professor Fox was formerly the Deputy Vice-Chancellor, Research and Enterprise at Swinburne University of Technology, where she was also the Founding Director of the Manufacturing Futures Research Institute. A bit of operational stuff. I have another microphone for questions later, so when we get to that, please wait for me to arrive before you launch. I'll just hand over to you now, Bronwyn. Thank you.
Thank you so much for the lovely introduction. And it's my great pleasure to be here to moderate this important discussion on the challenges of antimicrobial resistance. Why is this such an important discussion for us to be having? Antimicrobial resistance, AMR, is a looming health crisis, recently designated as one of the top 10 public health threats facing humanity by the World Health Organization. AMR has the ability to render some of the most critical antimicrobial drugs, for example, antibiotics, antivirals, fungicides and antiparasitics, completely ineffective. Losing effective antimicrobial treatments against infections would be catastrophic for health. It would undermine modern medicine, and the risk of routine procedures such as elective surgery or cancer chemotherapy would skyrocket. Without preventative action, it's estimated that by 2050, AMR could lead to 10 million people dying every year and cost the global economy some $100 trillion US. So we're really fortunate today to have two experts in this field join us, and it's my great pleasure to introduce our speakers. I'm going to be very brief, but I would like you to note that they are both, they have had distinguished careers and are widely recognised as passionate experts in this field. Our first speaker is my colleague, Professor Bronwyn Morgan. She's a research director on CSIRO's Health and Biosecurity business unit and the lead of the Minimising Antimicrobial Resistance mission, which was co-developed with the Commonwealth Departments of Health and Aged Care and Agriculture, Fisheries and Forestry. She's also an adjunct professor at the University of Technology, Sydney. Bronwyn was General Manager for the Australian Centre for Genomic Epidemiology, where she developed in-depth knowledge of antimicrobial resistance. Prior to this, she held numerous senior communications and project management roles that bridged academic organisations, publicly listed companies, government, non-government organisations in the UK and in Australia. Our second speaker is Dr. Jack Richards, an infectious disease physician and co-founder and scientific director of Zip Diagnostics. Jack has been an infectious diseases physician at the Royal Melbourne Hospital and Northwestern Mental Health for many years. He was formerly laboratory head at the Burnet Institute for Medical Research and Public Health for some 11 years. Zip Diagnostics Proprietary Limited is an Australian-owned, Melbourne-based biotech company focused on domestic manufacture of low-cost infectious diseases, point-of-care diagnostics. They have developed point-of-care diagnostic tests for COVID-19 and sexually transmitted diseases, including chlamydia and gonorrhea, and plan to extend the test menu to include viral hepatitis, respiratory viruses, vector-borne diseases, and tuberculosis. With a robust skill set that includes infectious diseases, medical diagnostics, molecular biology, malaria, life sciences and more, Jack brings a wealth of knowledge to the task of minimising antimicrobial resistance. I'd now like to invite Bronwyn to the stage, and after the two presentations, there'll be an opportunity to ask questions, so please prepare.
Thank you, Bronwyn, and it's a pleasure to be here today. Thank you very much for the invitation. Now, it's highly likely that 1 in 3 of you in this room will have received a script for antibiotics in the last year, because that's what the national data tells us. Hopefully it worked, You're all here. I'm guessing it did. But increasingly, antibiotics are failing, and particularly those that are most commonly used. And we have a saying that the more you use them, the faster you lose them. And compared with European countries and the UK and Canada, Australia actually ranks 7th highest in the world for our use of antibiotics in the community. And a significant proportion of what we use is deemed unnecessary or inappropriate. So microbes are essential to life. They occupy all niches of our planet, from the dark depths of the ocean to the even darker depths of our gut. And most don't cause infections. So some infections self-resolve, while others go on to be extremely serious and life-threatening, more so when our antimicrobial armoury fails. And that's what makes antimicrobial resistance so difficult to track. It is not just one disease, it is a feature of many infectious diseases. And these bugs move around from country to country and state to state. I came down from New South Wales to Victoria. I'm sure I've got some of them in my gut. And they're coming around at greater speeds than ever before as we become one enormous global village. So the global health and economic burden of antimicrobial resistance is clearly higher in lower to middle income countries, but it's not insignificant in Australia, with between 8 and 25 deaths per week in the state of Victoria. And we have this range because AMR deaths are really hard to estimate, and in part this is because they are hidden behind other diseases such as cancer. We're missing data, and that's really given us a false sense of security about the urgency of this threat to modern medicine. It's the reason I initiated this report with MTP Connect, and let me say these are conservative estimates that we have come up with. Now, while AMR can affect anyone at any age, it is our children and our elderly that are particularly vulnerable due to the high rates of certain types of infections, weakened immune systems, multiple comorbidities, and close proximities in terms of living arrangements. And it's even worse for our Indigenous populations. I was recently told that 60% of all deaths in an Alice Springs hospital from sepsis or bloodstream infections were Indigenous Australians. Our antibiotics are failing. So most of our antimicrobial medicines actually have natural origins, and this is really important to know. So they have a role naturally in maintaining balance in microbial ecosystems. So therefore, AMR is an evolutionary phenomenon where microbes adapt to survive and compete for space and nutrients. We didn't create AMR, but we are escalating it, largely through manufacturing antimicrobials at scale and then misusing, overusing, and even underusing them. There are thousands of antibiotic-resistant genes in our environment, but only a few hundred are of clinical relevance. Similarly, there are differences between how drug-resistant bugs evolve and spread between humans, animals, and the environment. That means that to mitigate the impact of AMR, we have to take a One Health approach. And this is where we recognise the interdependencies and interconnectivities of our ecosystem. I think we all now recognise the links between climate change and health. Suffice to say, it's making things much, much worse. And you can link that back to some behaviours. So for example, when it's dry and water is scarce, you might not wash your hands as often, and that creates an environment in which infections can spread more easily. A warming and less stable climate also increases disease rates, and notably higher temperatures increase the speed of pathogen growth and boost transmission. Heat stress can weaken humans' and animals' ability to cope with infections. Storms, sea level rises and floods force mass evacuations, can lead to sewage overflows, may contaminate freshwater supplies, and have been implicated in outbreaks of cholera and typhoid fever. A recent article by the scientific journal Nature listed more than 1,000 ways in which increases in climatic hazards have upped disease risk. So what do we need to do to mitigate the impact of AMR? And that is why CSIRO initiated an antimicrobial resistance mission, which, as Bronwyn said, was co-developed with the Department of Health and Aged Care and the Department of Agriculture, Fisheries and Forestry. So what do? Well, we go about connecting and coordinating stakeholders so that we can collectively facilitate and accelerate the development, uptake and adoption of solutions to prevent, manage and respond to antimicrobial resistance in humans, animals and the environment. We know that to be effective, we need greater awareness and action on AMR, and we see that as key to robust public and private sector policy development and investment in solutions. And this includes explaining how AMR is a core feature of environmental and social governance strategies, so where they feature in a board's ESG strategies. Last year, for the World Antimicrobial Awareness Week, which is held in November of every year, we produced materials. We all have a hand in AMR, and we targeted them with different graphics to different departments, be it agriculture or defence or education and environment. And we provided them to any states, state government and any organisations that wanted to use them so they could add their own branding, and Queensland obviously picked up on one of these. So we recognise also the need to include patient groups, because it's not just storytelling around the patient groups, but it's also the co-design of science and technology solutions with those end users. It's really not enough to innovate without a strategy for implementation and scale up that invariably involves behavioural change. Our clinicians desperately need new innovative medicines and new antimicrobials, but they take the best part of a decade to develop, and Australia, which is a small market, will often miss out. There's also no incentive to bring new antimicrobials to market because the current costs of research and development exceed projected earnings, and so the antibiotic research and development pipeline is drying up. So as an example, these are 20 novel antimicrobials that have been registered in either the EU or the FDA with the FDA since 2011, but only 3 are listed on the Australian Register of Therapeutic Goods. Limited access to existing and new antimicrobials compounds the AMR problem. And there's also a really fragile supply chain, and shortages of mainstay antibiotics are not uncommon, even in Australia. And that's why new payment models have been proposed globally. They're often called Netflix or subscription models. And they're being trialled around the world to see if we can make it worthwhile for companies to come back and invest in antimicrobial R&D and also secure supply of these vital medicines. So I'm sure you're all sitting here thinking, what can we do to help extend the effective life of our current drugs? And I think it also starts with surveillance. So investing in surveillance to help us understand where drug resistance is emerging and identifying hotspots, as well as whether an antibiotic treatment is going to be effective the first time around. So diagnostics have a really important role to play here, and you're going to hear more about that in a minute from Jack. New drugs are clearly needed, but it's unlikely we will ever keep pace with nature. Oh, it jumped many. Okay. So we need to know where we should be spending our time, our funding, and our energy to get the best possible outcome. And we've chosen to put more time and resources into minimising antimicrobial resistance. So working upstream, working on prevention, which we know is better than cure. And these are 2 separate pieces of work, but it's interesting to see where they both landed. So the foresighting report, which we produced together with the Academy, reflects the collective view of more than 100 experts. And there were 2 main recommendations in this report that was launched last year. The first one was to establish centralised coordination and leadership for AMR management to align and coordinate domestic and international activities. And the second one was to streamline and optimise the commercialisation process to support Australian AMR solutions so that are entering the market. And it also looked at a range of potentially impactful technologies such as integrated surveillance and sensing solutions, point-of-care diagnostics, vaccination technologies, antimicrobial surfaces and air sterilisation techniques. We had some fun examples as well that included surface sprays that change colour when pathogens are present, and toilets that detect and disarm harmful microbes before they reach our waterways. The second piece of work was based on a report, it's not yet in the public domain, but we produced for the Department of Health and Aged Care, and we assessed the R&D capabilities of Australia right through from fundamental to applied research. And then we took all those ones that are more at the applied end of the spectrum, and we worked with LEK Consulting to come up with a prioritisation framework based on impact so that we could decide what are those fewer bigger things that we were going to focus on. And we tested that in a workshop with colleagues from 6 other Commonwealth Government departments. And we came up with 3 priority areas. One is vaccines for drug-resistant pathogens in humans and animals. They're a bit harder to make for bacteria than they are for viruses like COVID, but there's certainly a lot of opportunity there. Another was an AMR-focused platform and implementation accelerator to support the rapid development and or uptake of AMR solutions. And the third was wastewater treatments to reduce and remove antimicrobial residues, so to take away that selection pressure, to help stop our bacteria evolving so quickly to become resistant to these medicines. We've spent the last 9 months building projects and project teams that encompass industry and academia around these science and technology priority areas. And there's a lot to be done, but now is the time to do it. And I was heartened to hear of the imminent release of Victoria's AMR strategic plan, because together we can secure a future where antimicrobials still save lives. Thank you.
Great. Well, thanks for that sort of lead in, Bronwyn, and thanks for the introduction, Bronwyn, too. I'm not going to say that too many times. Look, it's a real pleasure. I'm going to bring a bit of a perspective to AMR from the work that I do as an infectious diseases physician. And in that sense, I wanted to sort of pose to you some real-world situations that we encounter on a fairly much a daily basis, and pose those to you as clinical scenarios or vignettes for you to consider. So I'm going to place you in the position where you're going to be the medical practitioners. So the outcome of the patient is in your hands. The wrath of inappropriate prescribing will be on you as well. So I hope that you'll enjoy a little bit of a practical look into what we experience. The second part of what I wanted to do is bringing a perspective as a relatively new founder of a company, a medtech company that's based here in Collingwood, and some of the futures that we see as possible tools that might lend themselves to assisting health professionals and overcoming some of the issues of AMR that we're going to talk about in a moment. So there's tools and technologies that we can bring to play that will have an impact, but also a lot of challenges that might come with the implementation of those new technologies. So we'll touch on those points too. So imagine yourself, you're a GP. About 82% of people see their GP every year. So GPs are the front line of our health services. This absolutely essential role to play. So as the GP, Marcus, a 4-year-old boy, is coming into the clinic today. You know Marcus well. Marcus actually has cystic fibrosis. You saw Marcus 4 weeks ago and he was actually quite sick and had what you thought was pneumonia at the time, and you gave a course of amoxicillin. Fortunately, Marcus actually did really well, and he's been back at home and playing well over the last 4 weeks. But today his mother has brought him in with 24 hours of dry cough, a sore throat, he's got a runny nose and wheezy. So it might be much like your kids that you dropped off at creche this morning after giving them a quick Panadol. This is a really common scenario. The mother says these always go to his chest. This is a real typical expression that we always hear from parents. And we're going away on holidays next week, and this is a really important holiday for us. So we really don't want to be sick while we're away on holidays. So, as the general practitioners, what do you think the cause of this might be, and what should you do? I'm not going to sort of lag and go through all the different possibilities. Tim's looking nervously around the room. So that's a really good option. And so the context that we're working under here is the current context. What are the current tools that we've got available to us? So that's where you're at. As a GP, that's actually one of your options. So the majority of these will be non-serious viral infections. So rhinovirus, the coronavirus is not SARS-CoV-2. RSV and others, which don't require any antibiotics and don't require any antivirals, though they will be the majority of things. So you can send Marcus home with just bed rest and an iPad and get better over the next couple of days. However, you do have to think about the context epidemiologically of what's happening at the moment. There's a higher risk that this could actually be COVID-19. This is a 4-year-old boy who's highly susceptible, more susceptible than most 4-year-olds, to COVID-19 or severe influenza. So you can't necessarily rule that out and have to give that due consideration. So you might be sending this swab off to get more information, and you might be expecting a couple of days before that information comes back. Similarly, you've got to think about, he's got a sore throat. This could be a bacterial cause of pharyngitis, and so he might actually require antibiotics. He may not, you have to think about which risk groups he would fit into to warrant that, but that would be another consideration as well. But at this phase, you only have clinical judgment to go on. You also have to worry in a kid like this of having progressive pneumonia and lower respiratory tract infection, which has real mortality associated with it if we don't start antibiotics at the right time. And of course, in a child like this who gets recurrent episodes of respiratory infection and recurrent episodes of antibiotic treatment, AMR is a huge consideration. So what problems are we really experiencing here? As the general practitioner sitting opposite Marcus and his mother, what are the problems that you're facing trying to make this decision? You're highly trained, you've seen this before. Tim, yeah?
Just enormous pressure.
There's pressure. It's a lot of pressure. So there's pressure from different domains here too, isn't there? But one of the main problems that you're facing, I think, is you've got a lack of data. Okay, so you don't have true objective data. You're working empirically, you're working on good clinical acumen and experience, but there is pressure to prescribe either an antibiotic, potentially prescribe an antiviral. You are under pressure for not starting an antibiotic or an antimicrobial, which might bring true benefit to this child who's at risk. So you're potentially missing out on life-saving treatment. And you've got this social pressure too. You know, the mum and the family, quite rightfully, want to get away on a holiday and don't want that interrupted.
And
So,
you've got economic pressure. You're in a practice where the practice manager's saying get it in, get it out, and
Yep.
bill that patient.
you've got about a 6-minute sort of turnaround on the patients. They're double, triple booked.
Where's the client
That's right.
to some other practice?
So you don't have a lot of time to sort of sit here and sort of think this one through forever. So that's our current practice. So what I want to propose to you, what would a future practice potentially look like? So I'm coming at this, obviously I've got a bias in this presentation coming from a point of care manufacturing point of view, but the reason I've formed a company to do that is that I can see these sort of demands and pressures, and I think that we do have some tools to bring data into this clinical decision-making process. So if we still use clinical judgment, no one's saying that we just get a test and it just magically gives us all the answers. We still have to incorporate that into a clinical scenario and judgment. But if I've got a test and I'm running a test by the bedside, literally in the GP practice here, giving me a test result in 15 minutes, and in this case for Marcus, it's actually identified that he has influenza. So he doesn't have one of those other diseases. And now we have to think about, does he warrant actually antivirals for influenza treatment or not? So what were the benefits of this future scenario? Firstly, we avoided delays in obtaining the test results. We could have sent this away to a centralised laboratory. We might have got the results back the next day. If we were in a remote or rural area, we probably wouldn't have. We might have been days before we got a test result back. We were able to use real-time data within the clinical decision-making period to actually inform the decision that we made. And we actually created data which you benefited from as a medical practitioner, and the family actually benefited from that data too. So we all went through an educative process. And we also contributed data into the public health surveillance system. So whether it was a positive test or a negative test, that was actually data that actually helps support good public health surveillance. We also had data that then led into data-driven clinical decision-making. So we actually took away biased and subjective approaches to a more data-driven and objective data decision-making process. We avoided the use of empiric antibiotics and inappropriate prescribing. We reduced disease transmission potentially by sending Marcus home to isolate and spend time away from the creche. And we also decrease the need for ongoing consultations and coming back to the GP again. So there's a lot of barriers to this though, and we'll come back to these. I'm going to skip through this quickly. Obviously there's a new technology to deploy into this setting, which will come with some challenges. There'll be regulatory challenges to bring these sort of tests through. There'll be policy practice implications. There will obviously be workflow issues in a busy GP practice and how we manage that. And of course there'll be reimbursement. You know, who's going to pay for these sort of systems, because currently they're not covered by the MBS. So second scenario, you're now a GP visiting the aged care facility, and John is an 80-year-old who's had a fall recently and fractured his hip. He's actually been in hospital and had his hip replaced, and unfortunately the prosthetic hip has actually become infected. So probably about 80% of my practice in a tertiary hospital in Melbourne is actually dealing with exactly these sorts of problems. He's back at the nursing home, he's doing quite well on his antibiotics and he's recovering, going through rehab, and he's going to be on these antibiotics for at least the next few months. As the GP visiting that day, you're told that John is actually having abdominal pain, vomiting and severe diarrhoea. So what is the cause and what are you going to do about that? Well, you've seen this talk before, haven't you? No, spoiler. It's actually quite difficult to assess. So you're in an aged care facility as a GP, you don't have all of the tools at your fingertips, and sometimes it's extremely difficult. There is a long list of differentials to work through, and in some cases you don't know. And in some cases, this patient will get returned back to the hospital. He's got poor mobility. He's going back into a very complex medical environment where AMR is a genuine risk. May lose mobility simply by going back to hospital. So, but that is a genuine possibility. It could be that it's a non-infectious cause of diarrhoea. Seems that people's bowels are either running like a tap or they're clogged up like, Punt Road. So it could be one of these sort of normal kind of situations of bowels and seems to go up and down. It could be a diarrheal outbreak in the aged care facility. So it could be that we actually have to lock the place down. We have to isolate John and try and prevent the spread of this to other people. Or it could be an antibiotic-associated diarrhoea. And one of the ones that we worry about in particular is one called Clostridium difficile or Clostridioides difficile, which is a toxin-mediated cause of diarrhoea and can actually cause fulminant colitis and even death if it's not caught quickly enough. So again, we're in a data-free zone. It's just you and John and the aged care facility, and you've got to make a decision on what to do. So you could be changing his antibiotics for his prosthetic hip. You could be starting treatment for his Clostridium difficile. You could be sending him to the hospital. You could be sending off some tests. So the future could be that there's a point-of-care testing environment in aged care facilities. And it could be that John's going to the John and you're picking up a sample of this diarrhoea and putting it into a test and actually detecting the toxin of the Clostridium difficile in real time. And if you do that, you're actually able to nail down the diagnosis. You don't necessarily need to send him back to hospital. You can change his antibiotics, you can start to treat the Clostridium difficile infection there and then maintain his mobility and the current environment that he's in.
Does that pick up all the possibilities of what bacterium it could be?
Oh,
He's on antibiotics,
Sorry, what?
No, he's already on antibiotics.
He's on antibiotics already for his hip, but you would potentially change those antibiotics and you would put him on different antibiotics for Clostridium difficile, yeah. So there's a number of challenges that are facing caring for older people, and these become obviously really important as our population ages. So the aged are more complex, they have comorbidities, they have more difficult care needs, they often do get recurrent infections and they may be on sequential courses of antibiotics, exposing them to a high likelihood of generating AMR. They often have prosthetic materials in, which makes curing their diseases more difficult, more challenging. They often have higher rates of drug side effects from the antibiotics themselves or drug interactions from antibiotics with other things. They often have reduced mobility, and because they have reduced mobility, they then don't access healthcare services as readily. And so therefore, as health professionals, we're in a situation where we make empiric decisions more commonly because we can't get them into facilities where we'll get that extra information. And they're more vulnerable to infections. As we saw with COVID and influenza and other things, the aged are much more susceptible to disease, and so therefore there's increased need to initiate the appropriate therapy more quickly. And of course there's a lot of turnover with healthcare, visits, visitors, close nursing care and things like that, which also exposes the elderly to more risk of AMR. I'll quickly go through this last one. So in this instance, you're on a farm. It's down in Gippsland. So Farmer Joe has actually just come back from Bali for 2 weeks. Like all good dairy farmers, this is the first holiday he's had in about 30 years. And he notices that one of the cows is just a bit off, not producing milk. Looks like it's not eating very well. The udder looks inflamed, salivating from the mouth, which is a bit strange. And so Farmer Joe's a little bit sort of concerned about this cow. So what do you think the cause might be? The most common cause in Gippsland today would be mastitis. So common inflammatory infective condition of the udder, often bacterial, often does need antimicrobials, often requires the cow to be removed from the herd and milked, but for therapeutic reasons. It could be a local endemic disease like pestivirus, which does not require treatment but could require the cow to be isolated. Or it could be a disease that we really worry about as having a disease incursion into Australia like foot and mouth disease. So what are the problems here? Again, there's a lack of data. So you're out on the farm in Gippsland and you're worrying about this cow and you don't have information. But there's a lot of consequences at play here about which pathway you take in the management of this cow. So there's uncertainty, if it's mastitis, which antibiotics to use. Do you use gram-positive? Do you use gram-negative antibiotics? How long are you going to use them for? How long are you going to monitor for that? What's the cost of the treatment? Do you call the vet in? It's going to be expensive to call the vet in to see one cow. Most farmers are pretty reluctant to do that. What is the impact of this decision on the production, which is basically what you're there to do, producing milk? And if it was foot and mouth disease, what would be the implications of calling the authorities down to your farm to do the testing, to send that test away and to have a test result that's unlikely to come back for the next 1 or 2 weeks? Almost certainly it's going to shut down your farm. So the future care could be a bit similar. So again, AgVic could be out there within hours with a response team, could be running a point of care test on the farm, could be giving you a very quick answer in a few hours, sending off testing for confirmation of that. And in this case, let's say he had brought foot and mouth disease back from Bali, and then you're sort of shutting down the farm early on, stopping transmission to other cattle around the area. So there's a lot of challenges. We're worried about emergency animal diseases at the moment. There's a lot of foot and mouth disease, lumpy skin disease, African swine fever, avian influenza is cropping up at the moment. They're genuinely circulating. We have to have a genuine concern about these diseases and their incursion and be prepared to respond quickly. The market and the impact on the market is huge. If it occurs, these diseases are going to occur in remote and rural areas. There will be time delays in dealing with these issues. I want to. So I'll go through this quickly. Obviously, I wanted to talk a little bit about point of care tests today. These are complex technologies. We're not talking about mass production of RAT tests. I'm talking about highly integrated, complex systems which include complex reagents, integrated digital systems with workflow management, data management. They fit into data systems generally. So there's a lot that goes into manufacturing these. So these are the sort of jobs that we do at Zip, is recombinant protein production, freeze-drying lyophilization, automation robotics. We use digital imaging and AI systems for quality control. We run our own sort of software algorithms for quality control and batch release as well. There's challenges in implementing these point of care systems in the regulatory frameworks that we have at the moment. Obviously, there's a huge documentary side to the complexity of getting these through regulatory sort of submissions. There's variation globally between Australia, US, Europe, and there's a move towards harmonisation, but there's still significant differences in the regulatory bodies around the world. And the TGA is extremely supportive of Australian companies, but we're in the queue with everybody else as an Australian manufacturer. And just to finish off, I just wanted to give a sort of a timeline of where we're at the top. So at the moment, this is our typical consultation that we've just talked about a moment ago, where you're there seeing the general practitioner, you're having that initial consultation, you're being sent to a pathology for a sample collection, that's been sent to a centralised lab for a test result, that test result comes back a few days later, and then a second consultation to sort of pick up and manage the patient, as opposed to what we could move towards in the future with point-of-care testing. But lots of challenges to implement these sort of systems. So thank you.
Thank you so much. Two really riveting presentations. We would love to hear some questions from the audience. And just as we're heading over there, I would like to ask the first question, which, artificial intelligence has been a big topic this week. I've just come from the Fin Review Summit in Sydney. What role does AI have to play in the work that you are both doing? Bran, do you want to start? And do you want to jump up here?
It's really, do you want me to?
Yeah.
There's a lot of opportunity in using AI to tackle AMR. There's really the 4 big Ds, which is detection, dosing, diagnostics and drugs. So when we think about drugs, how can we use AI to quickly try and design some new molecules that the bacterial find it harder to become resistant to, and do fast screening based on what's already working, but also really creative generative AI type techniques to find new types of drugs. I'll let Jack speak to the diagnostics piece. The dosing piece is really important too. We're all, different body sizes, shapes, we metabolise things differently. You can use AI to predict the personalised dosing for different antimicrobials. Detection as well. If you start to overlay different data sources, so it might be geospatial data sources, electronic health records, the locations of things like aged care homes or camping sites. You can then use AI to look to see, and wastewater treatment plants, for example, where some of those hotspots of emerging drug resistance might be. Jack, do you want to talk about diagnostics?
So we're using AI in the sense of what we'd call narrow AI in a manufacturing sense. So with highly complex production, quality control is essential. And there's certain tasks that digital imaging, for instance, and digital image analysis can really bring up quality that in a way that people just cannot do. So we do a lot of image analysis and AI algorithms, sort of machine learning type AI. The other thing that we look a lot at is genetic sequence data. And so there's just this immense amount of genetic sequence data available to the degree that it's sometimes difficult to know what you're looking for. You have to find the small events sometimes in a sea of information. So to be able to sort of sift through data to find the really essential elements is really becoming more and more critical.
Hi, Roma Britnell, member for South West Coast. They were both really interesting presentations. Can I just clarify, so you can actually diagnose FMD on farm today?
No. These are future scenarios. So we've got a test that we have developed. It's actually in some validation testing at the moment in the UK, so it can't be validated in Australia at the moment. So
you possibly have the technology, it's not approved?
It's not approved and it's currently being assessed.
That's pretty exciting stuff, yeah.
We've finished some validation testing with CSIRO. Actually, just recently we had a report released last week for lumpy skin disease. So they've actually done some preliminary clinical validation for LSD, and we'll soon have some data on foot and mouth disease.
Okay. My actual question was more about, sorry, that was just another side interest of mine. But I came today having been to many of these presentations over 3 or so more decades, and I'm always interested as to why we don't do what we saw done during COVID, and that was back the doctors in when we saw that we needed as a world a vaccine, and there was a lot of nervousness around the vaccine. We backed doctors in and gave them that confidence to actually, with their profession not at risk, give the vaccine. What we haven't done, and we've known for 30, 40 years that we've got a massive problem with resistance, we haven't backed doctors in. I reckon that little boy, 4-year-old boy would have gone overseas or wherever they were going on holidays with antibiotics in their bag, because mum would have said to that doctor, this is going to turn bacterial, it's going to be a secondary bacterial. We need to back doctors in, we need to do more pathology, and we need to make sure we're not giving antibiotics out without some evidence that it's bacterial. And the only way you can do that is by telling doctors that you will back them in, and we'll stop doctor shopping so they don't lose a client. They're actually a patient, not a client, and we need a health system, not a business. That's where this problem starts. And I know there's all sorts of issues with, waterways and animal resistance in housed situations, but that's where the problem could have been stopped a long time ago or minimised a long time ago. That's where we should be campaigning.
Did you want to comment?
I agree 100%. So 70% of all antibiotics are prescribed in a primary care sector. One of the things we're looking at is how do we determine which of those are appropriate or inappropriate? And part of that comes with valuing pathology, whether it's a point of care test or whether it's at the pathology lab. And unfortunately, we also need a reimbursement model for point of care tests, because you can't expect the patient to be out of pocket. So really investigating and showing the value of diagnostics in those settings. And to do that, there's a couple of key infrastructure problems that need to be solved. One is when the GP sits there and taps into their medical record system, best practice, medical director, there's about 5 of them that we use in this country. How do you then, if you have used a point of care test, whether it's positive or negative, record that in the software system, link that to the script and the dispensing of the antibiotic at the pharmacy. So you can say, when we use point of care tests in primary care settings, we are reducing antimicrobial use in the community over this period by X%. So we really need almost like real-time prescription monitoring for antibiotics to demonstrate that feedback loop and the value of diagnostics.
Okay, can I add just one quick thing to that? Another thing that happens, I think, when a health professional sees a patient is there's a transaction happening. So it's not just about the clinical decision that's being made. There's a social event that's actually occurring, is that you're interacting with 2 people, and there's a transaction of information but reciprocal gain, or the patients want to leave with something, and it's not always just advice. So one of the circuit breakers for that transaction is a prescription, because you're leaving with something. So, and that becomes a problem. So sometimes there's an expectation of leaving with something. So that's why I also think data is something. Data and informing that dialogue is another way of giving something in that transaction, but it isn't necessarily giving a prescription.
Hi. What's the connection between the use of antibiotics in farm animals and AMR, I guess?
Well, they don't use as many antibiotics as us. 1 in 3 of us got a script for antibiotics last year. So there are some bacteria with resistances that circulate, as I showed in one of my earlier slides, just in the human space, some that are shared with animals, and certainly cats and dogs that live in our home often have some of those same genetics of those bugs, and then some that have environmental reservoirs and sinks as well. Ultimately, what we're trying to do is preserve the efficacy of antimicrobials so that we can treat sick animals and sick humans. And we also have a reverse, bidirectional. You can't always assume the direction. We know, for example, that birds that are migrating to Australia are picking up drug-resistant bugs from human waste and transporting them around. So there is a link, there's a clear link. You can't always tell the directionality. And every time you take an antibiotic, the bugs in your gut are evolving resistances, whether it's our gut, our cats and dogs' gut, or an animal's gut.
Okay.
The bells are about to ring. Please, one more question. I'll trust you. Yes, down the front here.
Sorry, my question is for you, and it's partly in response to your point about data being part of a transaction rather than a script. I think there's also a whole piece around that, in that the data needs to be easily consumable. I've left GPs or other health professionals and I've got an armload through of printouts and it's just overwhelming. I don't necessarily want to leave with a script, but yeah, I guess all I'm saying is there's that whole piece of work around making that data easy to consume by all sorts of audiences.
It's absolutely right. And it's not just the test result, it's not just the data. So I didn't mean to imply that it's as simple as here's the test result and this solves everything. All clinical management is a host of different elements, a host of different data points, effectively. It's understanding a patient, from a medical point of view. It's actually understanding them from a social point of view. It's obviously driven by clinical examination and test results as well. And that's kind of how you wrap it all up as a health professional. But what you're saying is exactly right. At the end of the day, you have to wrap it up in a way and communicate it in a way that's understandable to that individual. And that's kind of where the art of it really comes in, is that every single patient that you have, you wrap it up differently. And that's the challenge, is how do we communicate that for that person? So I totally agree with you. I think it's just one point that would add a tool for the clinician and could be the circuit breaker and part of that process. Yeah.
We have run out of time. Can we give our two speakers a big round of applause? Thank you so much. And before you head off, I just want to remind you that the next Science and Technology lunchtime presentation will be on sustainable housing and construction, transitioning to a circular economy. Thank you so much for joining us today, and we'll look forward to seeing you next time.